Hey, and welcome back to part two of our heart failure series. In this video, we will go through the signs and symptoms of heart failure, how it's diagnosed, and how chronic heart failure is managed.
In heart failure, there are some general features that do not belong strictly to left-sided or right-sided failure. Patients often complain of fatigue and reduced exercise tolerance because the cardiac output is low. Nocturia is common. They urinate more often at night because fluid that has pooled in the legs during the day is mobilized when they lie flat and can finally be filtered by the kidneys. The heart usually tries to compensate by increasing the heart rate, so tachycardia is common, and different types of arrhythmias may develop. On auscultation, you may hear an additional heart sound, either an S3 or an S4. In more advanced disease, you may detect pulsus alternans, which is a physical finding where the pulse alternates between strong and weak. And in late stage heart failure, patients can develop cardiac cachexia with weight loss and muscle wasting. Left-sided heart failure mainly affects the lungs because blood starts to back up into the pulmonary circulation. This causes congestion in the lungs, which is why breathing problems are the most common symptoms. Patients usually notice shortness of breath, especially during physical activity, and many of them also struggle to breathe when they lie flat, so they need extra pillows at night, and this we call orthopnea. Other patients can wake up suddenly at night feeling like they cannot catch their breath and may start coughing. This is known as paroxysmal nocturnal dyspnea, and it happens because fluid that has collected in the legs during the day moves back into the bloodstream when they lie down, and it increases the load on the heart. In more severe cases, fluid can actually fill the air spaces in the lungs, leading to pulmonary edema. Certain patients also develop what we call cardiac asthma, where high pressure in the blood vessels in the lungs causes the airways to narrow, leading to wheezing and coughing that can look very similar to true asthma. When examining these patients, you may hear crackles at the base of the lungs.
In left-sided heart failure, the apical impulse can be displaced. Normally, it's palpated in the fifth intercostal space at the left midclavicular line, but in heart failure with cardiomegaly, it's displaced laterally. Another sign that the legs and feet may be cold and pale, and that's because of reduced cardiac output. And also, we have peripheral vasoconstriction.
Right-sided heart failure is mainly a problem of systemic venous congestion and fluid retention. Patients often notice swelling in their lower legs, what we call peripheral pitting edema, because there is high venous pressure that pushes fluid out into the tissues. The liver can also become congested, leading to discomfort or pain in the right upper part of the abdomen, where the liver is located, and sometimes even jaundice. Gut congestion may cause nausea and a poor appetite, and in advanced cases, fluid can accumulate in the abdomen, leading to ascites. On examination, you often see distended jugular veins, and in some patients, you can see Kussmaul sign, which is distension of the jugular veins during inspiration. The liver may also be enlarged and tender, and in long-standing disease, both the liver and spleen can become enlarged, and we call that hepatosplenomegaly. A positive hepatojugular reflux is another important sign. This happens when you press gently over the liver and the neck veins become more prominent and stay elevated, and it shows that the right side of the heart cannot handle the extra blood. Together with the swelling in the legs, these findings form the classic picture of right-sided heart failure.
Now, let's move on to the diagnostics of heart failure. ECG can show abnormalities that either cause or support heart failure, such as atrial fibrillation, left ventricular hypertrophy, a wide QRS complex, also Q waves suggesting previous myocardial infarctions. Natriuretic peptides like BMP or NT-proBNP, they are useful but not specific, and they can be elevated in other conditions like atrial fibrillation, acute or chronic kidney disease, acute coronary syndrome, myocarditis, left ventricular hypertrophy, valvular diseases, and pulmonary embolisms. The levels can also rise with anemia, COPD, thyrotoxicosis, diabetic ketoacidosis, liver cirrhosis with ascites, and also severe infections like pneumonia or sepsis. Obesity, on the other hand, can give falsely low levels. When natriuretic peptides are elevated together with typical symptoms and signs, heart failure becomes likely. If BNP is below 35 picogram per milliliter or NT-proBNP is below 125, then heart failure is very unlikely. Our routine labs are also important, and they include urea, electrolytes, creatinine, and complete blood count. Also, liver and thyroid function tests. You should also check fasting glucose or glycated hemoglobin, also lipids, iron status. And the reason why we check these labs because, as previously mentioned, conditions of kidney, liver, or thyroid, also anemia, can mimic or worsen heart failure. Echocardiography is used to evaluate cardiac function and to measure the left ventricular ejection fraction. It also let us assess the size of the atria and ventricles. Also look for chamber hypertrophy and identify any wall motion abnormalities, which could suggest conditions like myocarditis or Takotsubo cardiomyopathy. Echo also evaluates valve function and help determine whether heart failure is mainly due to systolic or diastolic dysfunction. On chest X-ray, we can see an increased cardiothoracic ratio above 50%, which can be due to cardiomegaly, which means that we have an enlarged heart, or because of pericardial effusion, and that means that we have fluid around the heart. Now, with rising pressures, fluid starts leaking from the pulmonary vessels into the interstitium, and this can produce what's so called Curly B lines, which are short horizontal lines near the cosophrenic angles, and they represent the fluid within the peripheral interlobular septa. We can also see perihilar haze, and this is caused by fluid leaking into the central lung regions around the hilum. And as fluid continues to leak into the interstitium, it eventually enters the alveoli, leading to alveolar edema. And finally, pleural effusions may develop, and this can be unilateral or bilateral. And on chest X-ray, we look for blunting of the cosophrenic angles. There are also other tests that can be considered, such as stress echo, cardiac MRI, also CT coronary angiography, and the SPECT. These tests are specialized tests and are not done routinely. For example, if echocardiography is poor or the results are inconclusive, then we can do cardiac MRI, and it is recommended. It's also used when infiltrative or inflammatory diseases are suspected, such as in amyloidosis, Fabry disease, myocarditis, hemochromatosis, or sarcoidosis. Now let's talk about treatment. The main drugs in heart failure are loop diuretics, ACE inhibitors, or ARNI, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. The cornerstone of treatment is an ACE inhibitor or ARNI, together with a beta blocker and an MRA. ARNI stands for angiotensin receptor neprilysin inhibitor. For example, we have sacubitril valsartan, and an example of ACE inhibitors are enalapril and ramipril. And the commonly used beta blocker is metoprolol, and an example of an MRA is spironolactone. Loop diuretics such as furosemide are added when there is congestion to relieve symptoms. SGLT2 inhibitors such as dapagliflozin or empagliflozin are recommended for all patients with heart failure, and they have reduced ejection fraction. All of these drugs are recommended in reduced ejection fraction. In mildly reduced and preserved ejection fraction, diuretics are recommended if there is congestion, and the remaining drugs can also be considered. Device therapy can be used in selected patients, and the two main options are ICD and CRT. ICD stands for implantable cardioverter defibrillator, and it's used when the main problem is the risk of sudden cardiac death. If a patient has already had a life-threatening ventricular arrhythmia, an ICD is indicated. It's also used in patients with symptomatic heart failure and an ejection fraction of 35% or less, despite optimal medical therapy. And the patient has to have a reasonable life expectancy. The other option is CRT, which stands for cardiac resynchronization therapy. CRT is used when the heart is weak and the ventricles do not contract in a coordinated way. And this typically occurs in patients with a low ejection fraction and a wide QRS on ECG, and especially with left bundle branch block. In symptomatic patients, despite optimal treatment, CRT helps the ventricles beat in sync and improve symptoms and survival. According to ECS, which stands for the European Society of Cardiology, heart failure can often be prevented or delayed by treating major risk factors. Good blood pressure control reduces the risk of developing heart failure and lowers hospitalizations. As well as statins, they are recommended in patients with cardiovascular disease or high cardiovascular risk to prevent heart failure. In patients with diabetes and high cardiovascular risk, SGLT2 inhibitors reduce heart failure hospitalization as well. Others include lifestyle measures, which are physical activity, weight control, smoking cessation, and limiting alcohol intake. They are also recommended to reduce the risk of heart failure. That's it for today. I hope you found it helpful, and peace out.